Good evening, Puspendra sir.
Hello.
Good evening. Just I'm setting up my just Bluetooth setting. 1 minute, huh?
Sure,
Wait.
sir. Good evening, Sanjay sir.
Good evening. Can you see me clearly and listen me?
Yes, sir.
Okay. Thank you.
Am I audible? Hello, Shubhashree.
Yes, sir. Audible.
Okay. And another thing is, are you going to share my screen or should I share my screen?
So, as per your convenience.
Okay, better I will share my screen. Let me open
Sure.
first. Thank you.
Sure. Good evening, Karan sir.
Hello, hi, good evening. I hope I'm audible.
Yes, sir. Audible.
Okay, thank you.
Yeah, Shubhashree, if our initial speakers are there, we'll start definitely on time, huh?
Okay, sir. Okay, sir.
Hi, Dr. Karan. Hi, Dr. Pratik. How are you?
Sir, shall we start, sir?
Hi, Dr. Pushpendra, I'm good. How are you?
I am good too. Thank you. Thank you for your valuable time today.
No, absolutely. I am so, I really wanted to attend this session, and, you've actually picked up a very nice topic, very neglected. So kudos to you.
Yeah, and that's why you have to start and will the share why we selected this topic.
Sure.
Right, right. So yes,
Sure.
Subha, if we have Karan there after the talk is with Sanjay sir. Sanjay sir is already there. Just give a call to Savinay and Akshay if they are there. We can start. By the time if
Yes,
they can
yes.
join within 5-10 minutes, we can also start because it's 7 o'clock now.
Okay, sir. So, Shavanya ma'am will join shortly, and
Hmm.
Akshay sir also. So, we'll start.
Yeah, please.
Okay, fine, sir. Good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, it gives me immense pleasure to welcome all our esteemed faculty members, distinguished guests, and dear participants to today's IAIO Expert Insight session on Long NET. Today's program brings together an esteemed panel of experts who will share their valuable clinical experience and perspective on the evolving management of long NETs. We are especially honored to have with us our program director, Dr. Pushpendra Hirapara, consultant medical oncologist and hemato-oncologist, Shalvi Cancer Institute, Ahmedabad. A
वेबिनार
warm
ज्वाइन कर लो ना तुम लोग
Dr. Hirapara and all our distinguished faculty members. Without further delay, let's begin today's scientific program. To formally commence the session, I would like to invite Dr. Karan Sood, Assistant Professor, Medical Oncology, TMH Mumbai, for the chair introduction. Sir, over to you.
Thank you so much. If you could just give me the screen controls, I'd like to portray my slides.
Sure, sir.
Okay, excellent. Are you able to see my screen?
Yes, sir, visible.
Excellent. I'll just make it full screen, and I'm hoping that I'm audible, right?
Yes, sir, clearly.
Okay, excellent. So I know this is like a very nicely chosen topic I had already spoken. So, why we need the lung NET, what is the rarity, what is the heterogeneity, and why do we need MDT, that is the multidisciplinary tumor board. So, NENs are heterogeneous group of diseases, and we have SCLC along with large cell NECs along with carcinoids. So there's a very heterogeneous group, and it all depends upon how the pathology sees these slides. And you can see the carcinoids are to the tune of about 2%, and the typical to the atypical ratio is about 10:1. They tend to occur more frequently in younger women. And as we've already seen previously that like small cell cancers have a propensity to be there in patients who are smokers. But this is not true for carcinoids. So you'll find young women who are non-smokers. I mean, they've seen a couple of studies to make an association out of it, but they've not been, successful. And most of the things that, we know today are from small subgroup analysis, some underpowered trials, some retrospective cohorts, and mostly from the JEPNETs. So, the problem with this group of diseases is that the usual low volume cases leads to diagnostic delays, inconsistent management, and also people who have a high volume center, only those centers give you much of the data. So this is something of a difference of the 2019 versus the 2021. And I'm sure the subsequent speakers are going to talk about it. But what I was interested to talk about was in the next slide. So let's just quickly see what a typical carcinoid is. So it's usually an indolent, low mitotic, no necrosis, but an atypical would have a higher recurrence rate, more necrosis, probably a little more of a mitotic rate, more metastatic potential. And once we come to the SCLC and large cell, differentiation, these are fundamentally poorly differentiated and have a aggressive biology. I'll just show you a figure in a bit, but if you compare this to the table below, there is a new IACLC proposal to reclassify the lung nets or the NET into G1, G2, and G3. And you must compare this with the JEPNET and the medullary thyroid. And if you see, the tune is almost similar when you talk about the mitotic rate, that is less than 2 to 20 and more than 20. But in the lung nets, it's more than 10 and almost similar, Ki67s when you see. So it just depends on which organ the NET is. That tells you about the aggressiveness. Like we can also, probably extend this to a small bowel NET where we know the prognosis is much poorer. Hence, lung NET should be a different kind of a proposal when it comes as a histology in a patient. And this is something which is very interesting, which I got to know from a paper, that the spectrum is very varied. And once you see the left of the figure, which is the high-grade NENs, you see TP53, RB1 mutations, and mostly this is the SCLC domain. And when you go through this to the indolent NETs, you see how the TP53 and the RB1 losses are not there, but you have KRASs, STK11s, KEAP1s, and when you go to the indolent, the amount of mutations are much lesser. Hence, the landscape is very different, and the treatment modalities are also very different. So I think this is something which will be probably spoken about in the next slides. But you can go from an observation to liver-directed therapies, and in between you can have somatostatin analogs or everolimus cabozantinib, and especially the advent of PRRT. So we were also supposed to talk about why multidisciplinary tumor boards are important. So the most important part comes from the thoracic pathology. So you need to know that it is a NEN in the first go. Then you need to understand that it's a typical carcinoid or an atypical carcinoid. You need to understand from a good pathologist how is the mitotic rate, what is the necrosis, is the Ki67 lesser or is it more, is the RB1 staining, P53 staining there, done, not done, very, very important. And then in the multidisciplinary tumor board, if it is a resectable disease, definitely one would want to go in and resect the disease. But more importantly, upstaging of the disease could be happening along with the newer functioning imaging with SSTR PET, FDG PET, and also these things give you an eligibility for the PRRT therapy. But definitely the domain in which we practice is the systemic therapy. So to understand how this disease could be tackled, could a neoadjuvant therapy be given or an adjuvant therapy has to be given, and especially in the metastatic domain. Definitely radiation oncology and IR are important for local therapies, and oligoprogression, we know it's the landscape. If you talk about NENs in the liver, NENs at other sites which are oligoprogressive, you would want to either resect them or go for some kind of a liver directed therapy. And definitely if a patient has some or the other kind of functional issues, any type of functional such as increased dyspepsia or flushing or carcinoid heart disease, those things need to be covered by the supportive care. So I think I'll not go into this, but just to take a look at the left two columns, that is the phenotype and the preferred initial therapy. I am interested in the fact that you go from an active surveillance to lanreotide, octreotide, everolimus, then eventually you can go into a PRRT, which could be along with CAPTEM. Then there are further therapies like FOLFOX, GEMOX, and then you have multiple other tumor-directed therapies, which include tumor-agnostic markers such as DMMR, TMB high, and if you get some mutations like NTRK, they can also be done. So I think with that, this sets the context for the rest of the lecture, and I'll probably give it over back to Dr. Pushpendra to take it forward. So thank you so much.
Thank you, Dr. Karan. Thank you so much for the introduction and why we want to discuss today and what is the new things. Our next speaker is Dr. Sanjay Gandhi, sir. He is a very senior oncopathologist and highly interested in the oncopathology. He will guide us through the classification, pathology, biology for lung NET. Sir, we welcome you all. Please proceed.
Sir, I am audible? Hello?
Yes, sir.
Yes,
Audible.
sir.
Yeah.
Yes, sir.
Can you show my PowerPoint presentation?
Okay, sir.
Yeah.
Well,
Okay. All of the first, I will thank Dr. Pushpendra for giving me an opportunity to present the classification, pathology, and biology of neuroendocrine tumor of the lung. Dr. Karan sir has covered so many things in his brief talk. So How can I change my slide? Next slide. Okay. Can I have control to change my slide?
Yes, so you said next, then I will.
Okay. So I don't want to go through the dry classification by presenting the charts and tables, but I want to go through real world cases that challenges our diagnostic boundaries, which I have come across in last 1 or 2 months. Next slide. So there will be no classification table. There will be 3 cases and 3 diagnostic decision. Every case have a clinical presentation, H&E images, immunohistochemistry. I would like to ask the audience what final diagnosis and why it matters for patients, for oncologists, and for pathologists. Our pathologist job is to integrate the morphology, proliferation index, necrosis, cytology, and of course, biology of the tumor, means the molecular biology. Some of the ISC marker which I have used as a surrogate marker for molecular mutation. Next slide. Coming to the case 1 of 52-year-old male, patient is a non-smoker. On CT scan, there was a peripheral nodule, 1.5 centimeter in size. Patient also presented with brain lesion. I have received a biopsy from medical oncologist with biopsy, immunohistochemistry, and if adenocarcinoma, I should go for ALK and PDL1 and NGS, and if squamous cell carcinoma, ask for PDL1. What I see in histopathology is a beautiful organoid architecture. What we can see is a classic nesting pattern and trabecular pattern. Cells have eosinophilic cytoplasm and granular chromatin. Mitotic were extremely rare, difficult to find, less than 1 per 2 millimeter square. Necrosis was absent. Ki-67 was done and it was 8 to 10%. At this stage, I would like to ask, immunohistochemistry done, tumor cells positive for synaptophysin and INSM1. Anybody would like to classify this case typical or atypical carcinoid? Anyone? Is it typical or atypical carcinoid?
I think sir, Chi-67 is high, right?
Hello.
And there is
Yes.
a brain mets. So yeah, I do have my other colleagues also. Let's
Okay.
hear from them. So I think I should go with the atypical.
Atypical carcinoid. Anybody?
Yeah, sir, because of brain mat atypical.
Because of brain mets atypical. Okay. Okay. So I further next slide, sorry. Okay. So oncologists are used to see Ki-67 proliferation index and clinical presentation to classify the carcinoid tumor as a typical and atypical carcinoid. But according to the WHO classification, carcinoid and atypical carcinoid are differentiated by only 2 ways. Morphology, classical neuroendocrine architecture. Second is mitotic activity, and third is necrosis. If mitosis is more than 2, and if necrosis is present, we can call it as an atypical carcinoid. In our case, mitosis is less than 1 and necrosis is absent. So this is a classical case of typical carcinoid tumor. In WHO classification of neuroendocrine tumor of lung, do not let Ki-67 alone to redefine a pulmonary carcinoid, either typical or atypical. Still, Ki-67 is not included by WHO as in differentiating between typical and atypical carcinoid tumor. Next slide. So the classification that rules the matter to diagnose this case, yes, definitely Ki-67 is high, 8 to 10%. So we can suggest this tumor may behave more aggressively compared to typical carcinoid tumor. Tumor may have heterogeneity, may they have necrosis or increased mitosis in other part. But in this biopsy, this is a typical carcinoid tumor and it is defined as less than 2 mitosis per 2 millimeter square and no necrosis, while atypical carcinoid is 2 to 10 mitosis per 2 millimeter square and or necrosis. Ki-67 can be supportive in difficult setting, but is not the formal criteria to differentiate between typical and atypical carcinoid. Second case, next slide. Now I would like to go to the second case. It is a 65-year-old male with a 5.5 centimeter central mass. This is the biopsy, CT-guided biopsy I received. What I see in light microscopy is the pink area. This is the extensive necrosis. And on high power view, what I can see is a neuroendocrine architecture, nested pattern, trabecular pattern. Cells are apparently large. They have eosinophilic cytoplasm and many of them shows nucleoli. On immunohistochemistry, INSM1 was positive, synaptophysin was positive, and P53 was mutant type. So this is a neuroendocrine tumor with mitosis, necrosis, and large cell morphology. So I would like to now know audience what it is, a large cell neuroendocrine carcinoma or small cell neuroendocrine carcinoma.
I would keep it in large cell neuroendocrine carcinoma.
Large cell neuroendocrine. Anybody want to differ with this diagnosis?
Ki-67.
Ki-67 was high, nearly 80 to 85%.
And about synaptophysin,
Synaptophysin
TTF1
and
and
INSM1 positive. Yeah,
TTF1,
neuroendocrine markers
TTF1,
positive. Yes.
TTF1 was
TTF1
positive.
was also positive. Yes.
Okay, then it is a small cell lung cancer.
You treat as a small cell carcinoma. Okay, next slide. So we have a here differ of opinion, small cell carcinoma or large cell neuroendocrine carcinoma. So this is the classical case of small biopsy boundary and molecular reality. I have finally diagnosed this case as a high-grade neuroendocrine carcinoma because there is a definite neuroendocrine pattern. On immunohistochemistry, it shows positivity for synaptophysin and INSM1. P53 was a mutant type. As per current WHO classification, they strictly requires surgical resected specimen to diagnose it as a large cell neuroendocrine carcinoma. The most important thing, diffuse P53 immunohistochemical positivity indicates this is a mutant P53. So we are dealing with a high-grade carcinoma over low-grade carcinoid tumor. And the third most important thing, to call it small cell carcinoma, we should have both P53 as well as retinoblastoma mutation. I have not used retinoblastoma ISC in this case, but it is not always going with the molecular level. P53 is used as a surrogate marker, but retinoblastoma is not always used as a surrogate marker to check the molecular level. So this is, that's why I have reported this as a high-grade neuroendocrine carcinoma favors large cell neuroendocrine carcinoma. Next. So what separates the large cell neuroendocrine carcinoma from small cell neuroendocrine carcinoma? The large cell neuroendocrine carcinoma has large cell cytology apart from neuroendocrine architecture, which we have seen in this case, trabecular and nested pattern, prominent nucleoli, which was present in our biopsy, more abundant cytoplasm, and they shows neuroendocrine marker expression, synaptophysin and ISM1. While small cell carcinoma has a small cell, scanty cytoplasm, they have nuclear molding, inconspicuous nuclei, crushing artifacts. So both are high-grade neuroendocrine carcinoma. They show neuroendocrine positivity, but that does not diagnose this case as a small cell or large cell neuroendocrine carcinoma. We have to go with a morphology along with immunohistochemistry profile, and sometimes we can use surrogate marker P53 and retinoblastoma. Next slide. This is the case number 3. 70-year-old male, a smoker patient. I have received a bronchoscopic biopsy, and this is the whole image of that bronchoscopic biopsy here. And this is the microscopy where some viable tumor cells I found hardly. On morphology, these are the small blue cell morphology with nuclear molding, positive for pancytokeratin. They are also positive for INSM1 and synaptophysin. Ki67 proliferation index was high and P53 was mutant type. Next slide. P53. This is a P53, more than 90% cells, strong nuclear expression for P53. Previous slide. So can we confidently call this as a small cell carcinoma?
Yes, sir. I think yes.
We can call it,
Yes,
yes, sir.
not pathology.
Yes or no?
Yes. Yes, sir.
Yes. So according to you, we can call confidently it's a small cell carcinoma. But I will be cautious in this case. I have reported, described entire thing, whatever I see in the morphology, synaptophysin expression, P53 mutation, and suggest this is a small cell carcinoma in this 70-year-old smoker. But remember the one thing, limited tissue material. When we are come across the limited tissue material, our diagnosis arrogance should not override the precision of this small tissue material biopsy. Because similar case I have received 1 month back in a female patient, I have received for second opinion, similar morphology, cross artifact, loss of necrosis. When I did the immunohistochemistry, it was positive for pancytokeratin, focal weak positive for synaptophysin, P53 was mutant type. Then I called the medical oncologist and asked the history whether patient is a smoker, because patient is a female. She told me that no, patient is not a smoker. So I was cautious because focal synaptophysin positive, P53 mutant positivity in a non-smoker patient, I was reluctant to give small cell carcinoma and ask the oncologist to do repeat biopsy. Patient was reluctant to do repeat biopsy. So subsequent liquid biopsy was done and patient's biopsy suggests EGFR mutation. So most important thing, when we are come across with small tissue crushing artifacts, our diagnostic arrogance should not override the limitation of the biopsy. Next slide. Next slide. So a practical biopsy algorithm, definitely this was turned out to be small cell carcinoma in subsequent biopsy. Confirm epithelial malignancy. In this case, because of the scanty material, I have first performed pancytokeratin and it was positive. That confirms we are dealing with the carcinoma. Assess the cytological phenotype, morphology. Definitely whatever the small area was there, they were a small cell. And I have confirmed the neuroendocrine differentiation by synaptophysin as well as INSM1. If possible, we should assess the mitosis and necrosis. We should exclude the important mimics, particularly in small tissue, such as this can be a heterogeneous large cell neuroendocrine carcinoma, and that can show the crushing artifact and P53 mutation. Sometimes basaloid squamous cell carcinoma in small tissue can also show similar morphology with similar immunoprofile. So if the tissue is inadequate, communicate the limitation rather than giving the false precision. Next slide. So let's look at the biology. Why there are not simply a different grades, like a carcinoid is a grade 1, atypical is a grade 2, and carcinoma is a grade 3, because they are different biologically. Carcinoid and polydifferentiated neuroendocrine carcinoma are distinct groups, while small cell carcinoma have two definite mutation, P53 and retinoblastoma pathway, that is define it as a small cell carcinoma. While large cell neuroendocrine carcinoma, they are heterogeneous at molecular landscape. That we will see in next slide. Next slide. Next slide, please. Yeah. So this is the molecular landscape of lung neuroendocrine tumor. Carcinoid have mostly MAN inactivation and they have DAX and ATRX mutation. Most importantly, they have a low tumor mutation burden. While small cell carcinoma with extremely high tumor mutation burden and are associated with P53 and retinoblastoma mutation. This is the biological passport, T53 and retinoblastoma for small cell carcinoma. While large cell neuroendocrine carcinoma, molecularly heterogeneous, they may have similar to small cell carcinoma pathway, P53 along with retinoblastoma mutation, or they may have non-small cell carcinoma pathway. Along with P53, they lack retinoblastoma mutation and they may show CAP, KRAS or STK11 mutation. So how they differ from individual, not only on molecular landscape but also on light microscopy. Next slide. And before I go to my last slide, as a onco physician, you usually trapped in Ki67, especially in lung neuroendocrine tumor. Ki67 is high, therefore this cannot be a typical carcinoid. It is not like that. It's a wrong approach. Use one Ki67 cutoff to override lung carcinoid morphology. Better approach is review the morphology, recount the mitosis, reassess the necrosis. If mitosis is less, there is no necrosis, integrate Ki67 as a supportive information and not for a classification. And especially in limited crust biopsy, Ki67 may help in overall differential. If extremely high Ki67, we certainly exclude carcinoid tumor, but it does not replace the morphology. Next slide. So this is my 5 take-home message after this my entire presentation. First, neuroendocrine marker positivity does not mean neuroendocrine carcinoma. In recent last 5 to 6 months, I have seen so many cases of SMARC A4 deficient tumor. They show BRG1 loss and simultaneously they express the synaptophysin, but they are truly not neuroendocrine carcinoma. So neuroendocrine marker positivity does not mean neuroendocrine carcinoma. Morphology remains the cornerstone of the lung neuroendocrine tumor classification. Carcinoid, no necrosis, limited mitosis. And small cell and large cell carcinoma, small cell, molded, scant cytoplasm, hyperchromatic nuclei. Large cell neuroendocrine carcinoma, they are only diagnosed on surgical specimen, large cells with prominent nucleoli. None of these are an ISC diagnosis. And most important thing, when morphology, ISC and clinical with radiological findings are disagree, stop, reassess and communicate the limitation. Next slide and my last slide. So classification guides us, but the biology of the neuroendocrine tumor defines us. Thank you, and I would like to open for the discussion.
Thank you, sir. Thank you very much. Your years of experience has definitely enriched us a lot in this small, crisp but short talk. I think I would like any attendees to put their questions in the chat box, and would like to invite our dear friend and colleague, medical oncologist, Dr. Savinay. She is a consultant at Blood and Cancer Institute, Surat, for diagnostic approach. Welcome, Dr. Savinay.
Good evening, everybody. Thank you, Pushpendra Bhai. Thank you, Team IAIO, for the opportunity. Requesting Team IAIO to please keep this in slideshow mode. Yeah, okay. So, after listening to Dr. Karan and Dr. Sanjay sir, I guess most of my work has been made easy. So I will just skip the part which is overlapping. And next slide. So Basha, I guess the...
Yes, ma'am, sharing.
Yeah, sure. Okay. Oh, so the topic for my today's talk is diagnostic approach, except staging and imaging, which will be taken by my fellow colleague and dear friend, Dr. Akshay Tajpara, in the next session. Next slide. Yeah. So I'll just simplify it. Now, 5 questions which every lung NET workup must be able to answer. First of all, is it neuroendocrine or not? Which has already been discussed in the previous session. Morphology and then confirmation with an IHC panel. Secondly, neuroendocrine tumor versus neuroendocrine carcinoma, because these two are biologically very different malignancies. Their prognosis is different, and obviously the treatments are also different. Thirdly, with lung entities, whether it is typical or atypical carcinoid. Now, we have already been through the classifications. Fourthly, is the lung the primary site of this malignancy? TTF1 will be unreliable in this case, and OTP is the discriminator. And lastly, functioning tumor or not. Next slide. Okay, so neuroendocrine tumor of lungs, basically the carcinoid tumors. If we look at the incidences and prevalence, the typical carcinoids are 8 to 10 times more commoner than atypical carcinoids. 65% of these patients are females with a median age of 60 years at the time of diagnosis. Now, there are some very basic differences between typical and atypical carcinoid. Typical carcinoid will not be having any established smoking correlation, whereas in atypical carcinoid, we can get the correlation with the history of smoking. These are very slow growing, well circumscribed, and endobronchial lesions. With typical carcinoid, it is highly uncommon to get metastasis at the time of presentation, but it can be seen in up to 2/3 of the patients in case of atypical carcinoid. Although the 5-year overall survival is very different, it is 84% in typical carcinoid versus 64% in atypical carcinoid. And with Larsen neuroendocrine carcinoma, it can go as below as 17%. It is the commonest primary lung neoplasm of childhood, and about 8% are presenting in the second decade. Next slide. So, most of these carcinoid tumors are basically central. Roughly 60 to 85% are central tumors, and they will have their own presentation. They are most commonly presenting as a recurrent or non-resolving pneumonia in the same lobe, hemoptysis, cough, wheeze, dyspnea, chest pain, and most of the time they are frequently labeled as asthmatic or COPD for years. Around 10 to 20% of these cases can be having a peripheral tumor, which is usually an incidental nodule, and they are asymptomatic at diagnosis. Now, the detection is increasing nowadays because of the incidental cross-sectional imaging. So, the crux of this slide is any tumor which is a fixed unilateral, poorly bronchodilator responsive wheeze or the same lobe consolidating twice should prompt a bronchoscopy, not a third course of antibiotic. And reported time from symptom to diagnosis often averages around 2 years. Next slide. So regarding the hormonal syndromes, actually they are very less common in case of lung carcinoid as compared to the GI neuroendocrine tumors. Around 2 to 12% of the patients can have carcinoid syndrome. And whenever a lung entity is having carcinoid syndrome, it implies that the patient might be having liver metastasis. Now, ectopic ACTH secretion leading to Cushingoid appearance is seen in around 1 to 6% of the patients. And when we are suspecting this, we must get the ACTH, 24-hour urinary free cortisol, and serum cortisol levels done. Rarely, patient can have SIADH hypercalcemia, and also because of the ectopic growth hormone secretion, patient can have acromegalic features as well. Next slide. So this is something which I would like to discuss, that is DIPNEC, which is diffuse intrapulmonary neuroendocrine cell hyperplasia. So that is the pre-invasive lesion. Now, most of the middle-aged females who are having no history of smoking or maybe former smokers, presenting with complaint of years of coughing and breathlessness, which has been labeled as asthma. So when we get their pulmonary function test done, it reveals an obstructive spirometry with air trapping, and the scan reveals multiple bilateral non-calcified nodules. So this is the typical presentation which is seen in DIPNEC. And surprisingly, even 40% of these patients can have chromogranin A elevation as well. Now, WHO 2021 has split this definition into pathological DIPNEC and clinical DIPNEC. So pathological is just we get the neuroendocrine cell hyperplasia with constructive bronchiolitis. Clinically, patient of obstruction plus the typical nodule pattern. Why it matters is kitla patient, but sorry. So tumourlet is less than 5 mm in size, and anything which is more than equal to 5 mm is by definition a carcinoid. Next slide. Okay. Now, interestingly, around 5% of lung carcinoids can be associated with Men's syndrome, and 2% of these Men's syndrome patients can also develop a thymic carcinoid. Most of these patients are male. So, when is the testing for MEN1 indicated? When the patient is having a very young age at diagnosis, there are multifocal or multicentric carcinoids, synchronous primary hyperparathyroidism, pituitary or pancreatic neuroendocrine tumor. Suggested family history is there, or whenever there is a thymic carcinoid in a male patient. So in these cases, we must be prompted to test for MEN1 syndrome. Next slide. Okay, now this is something which is very interesting. Actually, the older school of thought, most of the time serum levels of chromogranin A were done and they were used to even monitor the disease status. Now, the sensitivity of chromogranin A in a pulmonary carcinoid is very less, around 35% only. So we must not be ordering reflex testing. If there are symptoms suggestive of functional tumor, then only we must order the relevant test. Like if there is flushing or diarrhea, we can get the 24-hour urinary 5-HIAA testing. If we are suspecting Cushingoid features, then ACTH and urinary free cortisol. If there are acromegalic features, then IGF-1 growth hormone and GHRH. Now, the very important thing regarding chromogranin A is if we do want to test it, we must get a 2-week off period from proton pump inhibitors, because the use of PPIs can also raise chromogranin A up till 2 to 4 times the normal value. So this is something, this is a clinical pearl which I wanted to bring to notice of everybody. Next slide. So I will skip this slide because it has been discussed in detail before. Next slide, please. So again, this has also been discussed, but for the neuroendocrine IHC markers, the most commonly which has been used till date is a synaptophysin chromogranin A. Recently, a new marker is INSM1, which is very sensitive and specific. NET versus NEC, that is Ki67, RB, and T53. So, and then lung primary, we have this TTF1 and OTP levels. Now, sensitivity of TTF1 is less, but OTP is a very relevant marker. And if we are ever suspecting a gut or pancreatic primary, then we can get the CDX2 testing done. Next slide, please. So, yes, so Ki67 actually, unlike the GI neuroendocrine tumors, where Ki67 has been used to classify them into grade 1, 2, 3, Ki67 in case of lung NET is used to differentiate between NET and NEC and not the typical versus atypical carcinoid. We have already discussed that mitotic count of less than 2 and absence of necrosis will make it typical. The other side, it goes into atypical. And if the Ki67 is more, it just makes it into neuroendocrine carcinoma. And there is no cutoff reliability which separates typical from atypical carcinoid here. There is not a defining criterion in WHO 2021 as well. Next slide, please. This is a very important thing, actually. Sometimes we can get a biopsy report which says that it is a typical carcinoid. But 45% of the atypical carcinoid were underclassified as typical carcinoid on a biopsy. So, typical carcinoid on a resected specimen is something which we can be sure of about. But if on a biopsy we are getting a typical carcinoid, it can be a misleader as well. Next slide, please. And again, carcinoids are not early small cell lung cancer. This has been a myth every time. So carcinoid is having a tumor mutational burden of 0.4 mutations per megabase. And the mutations are different. TP53 and RB1 alterations are very rare here. In large cell neuroendocrine carcinoma, we are having TP53 mutation in 90% of the patients. And there are two groups in LCNEC. It can be a small cell lung cancer like lesion, or it can be a non-small cell lung cancer like mutation. Chemotherapy implications are retrospectively, there are no prospective trials as such. In small cell lung carcinoma, what we are getting is a biallelic TP53 and RB1 inactivation in virtually all the tumors. There is Notch family inactivation in 25%, and there are various other exploratory mutations coming up. So, in practice, there is no molecular test needed to diagnose or grade a lung NET. Reserve germline MEN1 for clinical suspicion and consider NGS in large cell NEC, where actionable drivers and the SCLC-like versus NSCLC-like split may inform chemotherapy choice. Next slide, please. So what to keep in mind from Monday? Basically, it is already Monday. So suspect carcinoid in a fixed unilateral V's or a lobe that consolidates twice. The delay is diagnostic, not technical. Screen hormones by symptoms, but in ectopic Cushing's, look at the lung. Up to 40% harbor a bronchial carcinoid. Do not order chromogranin A reflexly. 35% sensitivity in pulmonary carcinoid, and stop proton pump inhibitor 2 weeks before if we do. Mitosis per 2 millimeter square and necrosis define the tire. Either criterion alone makes a carcinoid atypical. Ki67 separates neuroendocrine tumor from neuroendocrine carcinoma and not typical from atypical. There is no lung NET-G3 outside a study. A biopsy saying typical carcinoid undercalls atypical roughly half the time. Regrade on the resection specimen. Thank you.
Thank you, Dr. Savini, for on time and to the point and crisp talk. Next, so there are basically two questions in the chat box, and Sanjay sir has replied the first question. I will say, as a clinician, we need to see whether if the biology is being different and the symptoms are not correlating with the pathology, then we need to discuss and we need to investigate more. The second question was early diagnosis of lung cancer. Can we do prognosis good? Yes, when it's there for, I think, majority of the malignancy, early diagnosis with better outcomes. So next, I would like to invite my colleague and dear friend, Dr. Akshay Tajpara, for imaging and the role and how it helps us in the management of NET of lung. Thank you. Welcome, Dr. Akshay.
Thank you, sir. Thank you for inviting me here and having me here. So today's topic, which has been assigned to me, is imaging in neuroendocrine tumor in lung. If you could share the slides, I will start the presentation. Okay. So we will discuss about the imaging spectrum in neuroendocrine tumors with a focus on lung NETs. Next slide, please. So this has been discussed multiple times before. The biological spectrum ranges from typical carcinoid to small cell lung carcinoma. SSTR, that is somatostatin receptor expression, is high in typical carcinoids. And as we move towards an aggressive disease, it keeps on decreasing. So the primary imaging modality will also be defined based on the SSTR expression. Next slide. So anatomical imaging, mostly whenever we think of a neuroendocrine tumor, what comes to our mind is a gallium DOTATATE or DOTATOC scan. But contrast enhanced CT is still irreplaceable. The anatomical imaging is best done by a CCT or a MRI. So mostly it would reveal a central lesion likely to have an iceberg effect with a small luminal lesion and a large extraluminal mass lesion, or there could be a solitary peripheral lesion. The main disadvantage of a CECT is atelectasis and post-obstructive pneumonitis can obstruct the true primary tumor size. And in case of liver metastasis, especially when there is an unknown origin liver mets is there, MRI could be useful. And when we are suspecting brain metastasis, MRI can be useful. Next slide. So what we use in imaging for NETs is a dual tracer molecular concept. The SSTR axis, that is the somatostatin receptor expression, is the one which is targeted for low grade tumors. We use most commonly a 68 gallium DOTATAT or a DOTATOP. The previously used 111 indium is no longer recommended, and preferably a 68 gallium DOTATAT should be used. 64 copper-based imaging studies are also now in use, but most commonly we use a gallium-based assay. The metabolic axis, it is the conventionally used FDG PET. It is more likely to be useful in rapidly dividing cells. So in large cell neuroendocrine carcinoma or a small cell lung carcinoma, and in some of the atypical carcinoids which are having high Ki67, FDG PET, 18 FDG PET would be useful. As we know, it relies on the aerobic glycolysis, that is the Warburg effect. And the flip-flop phenomenon, which is very specific for neuroendocrine tumors, suggests tumor progression in the form of tumor dedifferentiation. There is a clonal evaluation wherein a low-grade tumor suddenly loses SSTR expression and gains intense FDG avidity, indicating overall a worsening prognosis. Next slide. So where do we use this somatostatin receptor PET? Mostly it is used for primary staging. Whenever a diagnosis of atypical or a typical carcinoid is made, a primary staging evaluation includes a gallium DOTATOP or DOTATAT scan. There could be an unknown primary, most commonly in the form of liver metastasis. So unknown primary detection can also use SSTR PET-CT. Theranostic biomarker. This is very important. Those patients who are planned for peptide receptor radionuclide therapy, PRRT, as well as those patients who are to be planned for an octreotide therapy. So SSTR PET works as a predictive imaging whether the patient is likely going to respond to the treatment or not. And in the management impact, so around 25 to 35% of lung NETs get upstaged when a CT alone is done compared to a PET-CT. Next slide. So where do we use FDG PET-CT? So not all lung NETs are SSTR positive. As I mentioned earlier, high-grade tumors like small cell carcinoma and large cell NEC, as well as atypical carcinoid with high Ki67 and high mitotic indices, would be more likely to have a FDG avidity than SSTR expression. For a rapidly progressive disease, again, a FDG PET-CT comes into picture, and it is also of prognostic value. When the patient's FDG scan is positive and SSTR is negative, it suggests an aggressive biology, a poor survival, and a lower response to PRRT or SSA, and a higher response rate to cytotoxic chemotherapy. Next, please. So based on this dual tracer protocol, we have this NET-PET score. It utilizes both of the SSTR expression as well as FDG expression, where we do both of the PET-CT as well as SSTR PET, FDG PET with SSTR PET. Higher the NET-PET score, poorer is the prognosis and overall survival. NET-PET P1 has the highest SSTR expression and excellent PRRT candidate. On the contrary, a NET-PET P5 would suggest more likely a high-grade small cell or a large cell NEC. And PRRT would no longer be useful in those patients. Chemotherapy would be preferable. Next. So theranostics and PRRT patient selection. We treat what we see. That's why we do a SSTR expression, and those patients who have a good uptake are candidate for PRRT therapy. And we see what we treat. So once we have started patient on PRRT, most likely we would be doing a repeat scan to look for the response. So there is a modified Krenning scale, which is PET based, useful for this selection criteria. Grade 3, that is uptake more than normal liver, is the threshold for starting PRRT treatment. Next. So there are some diagnostic pitfalls when we use a SSTR PET. And most likely is a false negative one in those patients who have an aggressive disease or a dedifferentiated clone. We might end up having a typical carcinoid on a biopsy, but because of tumor heterogeneity, the patient could have dedifferentiated clones, which would be SSTR negative, leading to a false downstaging of the tumor. Also, just like normal FDG PET, false positives could be there in inflammatory conditions or some other neoplasms. And anatomical CT pitfall, as I mentioned earlier, a CCT could not be a good diagnostic test for small liver metastasis and brain metastasis, as well as some endobronchial small lesions could be missed on a CT. Next slide. So, recommended imaging workflow algorithm. How do we decide which patient has to be sent for which investigation? So in one word, if I could summarize, it is differentiation dictates the tracer usage and biology dictates the modality to be used. For a well-differentiated tumor, a typical carcinoid or an atypical carcinoid with a lower mitotic index, a CCT is generally the first investigation to be done. It will give an idea about the anatomical staging as well as a surgical planning if needed. And once the CCT has revealed any lesion, an SSTR PET would be helpful in overall staging of the patient. At the same time, if a patient has a poorly differentiated carcinoma, a CCT of that local part, followed by an 18 fluoro FDG PET CT would be useful with an MRI brain. Next slide. So I would like to before ending the presentation, I would like to give an example for the same. We have a case study with a patient of a 42-year-old female patient who came with chronic cough and mild hemoptysis. Her CCT revealed a 2.5 centimeter central right lower lobe lesion with endobronchial extension, and her biopsy showed a typical carcinoid. Ki-67 was less than 2%, and she was being planned for a curative intent surgical resection, that is a lobectomy. However, when she was sent for a 68 gallium DOTA-TET PET CT, 3 different lesions were revealed on thoracic spine T4, T7, and T9, which represented occult bone metastasis. So before any curative intent planning, and DOTA-TET PET CT becomes essential. Next slide. The second case is about the flip-flop phenomenon as described earlier, which we see in cases of atypical carcinoid. A 65-year-old male who had a history of atypical carcinoid was on octreotide therapy for 3 years. Then the patient had a rapid progression clinically in the form of pain, fatigue, and rapid weight loss over 2 months. CCT showed multiple liver metastasis. A dual tracer imaging was done, which showed decreased SSTR PET uptake and increased 18F FDG PET, showing the disease progression. So it demonstrates the classical clonal dedifferentiation, the flip-flop phenomenon. If the patient is scheduled for a PRRT, it would not be effective in this patient and has to be shifted to a platinum-based chemotherapy. Next slide. So there are many advances which we might see in NET imaging. As I said, the 64 copper-based imaging is also now being used, as well as there is one 68 gallium NODAGA which has been tried for it. It binds to both the active as well as inactive somatostatin receptors. And then F18 labeled SSTR tracers are also being tried now. Next slide. So if I summarize, the key takeaways would be biology dictating the modality. Always use SSTR PET for well-differentiated typical carcinoids and FDG PET for high-grade lesions or aggressive atypical carcinoids. CCT remains mandatory. A SSTR PET should not be the first investigation. A CCT of the local part should be the first investigation to be undertaken. dual tracer identifies risk. So in cases of atypical carcinoid, it remains a gray zone, and most likely in those patients, we might end up using both the imaging simultaneously. And theranostic gatekeeper, PRRT requires confirmation of SSTR uptake higher than the liver background across all target lesions to ensure therapeutic efficacy. Next slide. Thank you. That would be all from my side.
So thank you very much, Dr. Akshay. If there is any questions, we'll take in the question and answer box. There was one question which was asking about the percentage of synchronous and metachronous mets in NET. So basically, it depends upon the primary organ of origin, whether it is GI versus pulmonary, and also on the grade. So basically, in a high grade NET, if we are talking about the pulmonary NET, then synchronous is more common. Different percentage in different series, but approximately higher. So 60 to 65% synchronous, then and less likely is metachronous. With that, I would like to invite my dear friend and colleague, one of the finest surgeon. Yeah, please, Akshay.
I'm
Yes.
sorry to interrupt. There is always one question about 68 gallium DOTA TET versus DOTA TOC.
Yeah.
So I wanted to give a short clarification. Almost
Yeah, please.
both can be used and both are changeable in their usage. The DOTA TET has been used conventionally in most of the trials, like the NETTER-1 and the NETTER-2. It has a higher affinity for SSTR2, which is most common SSTR receptors. And the DOTA TOC has higher affinity for SSTR3 as well as 5. So overall, DOTA TET would be very sensitive, but in cases of small liver metastasis, DOTA TET is better because the background uptake is less. So we can better visualize liver mets in those patients. However, it is used interchangeably.
Thank you, Dr. Akshay. And I would like to invite my dear friend, colleague, and one of the finest surgeon, Dr. Pratik Gautam, for his. He is basically assistant professor at IMS and some medical campus, Bhubaneswar, in the Department of Surgical Oncology. He would be discussing the surgery, nodal management, and follow-up for the localized disease of pulmonary NET. Welcome, Dr. Pratik.
Thank you, Pushpendra Roy. Thank you for the invite. My previous speakers have already covered a lot of things which I plan to cover. Could I get the screen sharing, please? Am I visible?
Yes, sir, visible. Lights
Okay.
are visible.
Thank you, Pushpendra Roy. I'd like to begin. I am Dr. Pratik Gautam. I'm an assistant professor in the Department of Surgical Oncology at IMS and some hospital campus to Bhubaneswar. I'll be speaking on the surgery for localized disease. Coming to the basics, a neuroendocrine tumor actually originates from neuroendocrine cells. So it has two parts, a neuro and an endocrine part. So the tumor receives nerve input and it secretes some or the other hormone. It may cause symptoms or it may cause some pressure symptoms. So since 2021, this terminology has evolved into neuroendocrine neoplasms, and it encompasses both NET as well as NECs, which we are going to talk about. So lung is the second most common site for an NET. 2% of all the primary lung tumors are adenoids. And as discussed previously, around 60 to 70% are central and 20 to 30% are peripheral.
Sorry to interrupt, sir. Sir, we kindly request you to share your screen in a presentation mode.
Sorry. Is it okay now?
Yes, sir. Fine.
Okay. 20 to 30% are peripheral tumors and around 60 to 70% central tumors. And the epidemiology, the incidence as well as the prevalence, both are increasing. How do they present? Yes, it has already been discussed. And peripheral tumors are usually asymptomatic and they're incidentally found. And central tumors, they cause symptoms like cough, wheezing, and they can cause atelectasis. Minority can cause carcinoid syndrome. So the exact topic that I will be talking about is how much lung to be resected, how many nodes to be removed, and how long to follow. So the pathology report, as it has been discussed, it generally, as sir already described, the difference between typical and atypical and a neuroendocrine carcinoma. So I would like to emphasize that part, that a biopsy is usually taken with an artifact with a forceps biopsy. So it is a crust tissue. So you can never decide whether it is a typical or an atypical only based on the preoperative biopsy. The final specimen will only let us know whether it is a typical or an atypical tumor. So these are the cells, these are the slides which has already been discussed. And two things in the staging that is very important. It has been changed in the new latest TNM staging, that N2 is N2A and N2B. N2A is a single ipsilateral mediastinal or subcarinal station, and N2B is the same mediastinal and subcarinal station, but multiple stations if they're involved. So according to that, if it is a T1 tumor with an N2A node, it is now staged as 2B. It is N2B. It's the same size tumor, but if it's N2B, so if multiple stations are involved, then it is staged as 3A. So the same nodes, but a different stage. So it has a different implications for the follow-up as well as the treatment. So the station level labeling of node packets is necessary. Earlier, what used to happen that surgeons used to send every mediastinal nodes as a single packet. But now it has this importance for staging will requires that each nodal station should be labeled separately while sending. As discussed, Ki67 may become important, but it is still not in the WHO guidelines for classification. So the TNM staging, less than 3 centimeters is T2, 5 to 7 is T3, and more than 7 is T4. And as discussed, N2A and N2B have a single ipsilateral mediastinal nodal station or multiple. That difference is the stage here. From 2B, T1, N2A can become a N2B just because one single node of a different station may be positive. Preoperative assessment also has been discussed. I'll skip that. And as Dr. Akshay said just before me, you cannot image your way out of staging. So FDG PET has and dotated bit both have low sensitivity but high specificity. So the results means if it is positive, then you can definitely say that the node is positive. But if it's negative, it does not mean anything. It does not preclude surgical removal of the or surgical nodes. And biopsy decides which metabolic testing to do. Gallium-68 dotated PET is better in a neuroendocrine tumor with grade 1 neuroendocrine tumor where more receptors are expressed. Well, if it's a carcinoma, it's more hypermetabolic. 4 principles that should be taken care of. That complete, that is R0 section must be achieved. So we should try to preserve every lobe, as much lung as we can. So sleeve resection or bronchoplasties are preferred over pneumonic. And nodes, as discussed, should be staged systematically. So according to stations, and 3 of them must be mediastinal, and it should include the subcarinal station nodes. And now is the era of minimal invasive surgery. So gradually VATS and robotic approaches, they are much more coming up. So it should be preferably done in minimal invasive technique. The types of lung cancer surgery. It can be a wedge resection. It can be a segmental resection where an anatomically segment is removed. Each lung has almost 10 segments. So one segment anatomically removed is a segmental resection. Lobectomy, the right lobe has 3 lobes. So one of them lobes can be removed, or a pneumonectomy where the entire lung is removed. These are the lung segments. So if one of the segment is removed, so entire draining system with the lymphatics, they are removed. So it is supposed to be a more technically challenging surgery, but it is more rewarding for the patient. Then one thing that has had me confused during my residency days was what is a sleeve resection. So sleeve resection is somewhat like this. If this in this example, this is left bronchus tumor. It's a central tumor located in this bronchus. So we can remove this part, and the lung here will be still attached. So even after the tumor is removed, the lung can be preserved. So lung can be preserved and pneumonectomy can be avoided. To better exemplify, you might have seen a full sleeved cert. So imagine this is the trachea, this is the bronchus, and this is the lung. And we have a tumor, suppose here. So we can resect this tumor and rejoin both the sleeves. So we can convert a full sleeve shirt to a half sleeve shirt, hence the term sleeve resection. And if along with the bronchus, vascular resection is done and anastomosis is done, so that is a vascular sleeve resection. That is also possible. Pulmonary artery and pulmonary vein, they can also be rejoined. For a typical carcinoid, a sublobar resection is defensible. So even if we do a sublobar resection, that is either a wedge resection or a segmentectomy, almost same. The 10-year survival is 83% with a lobectomy, and for a sublobar resection, 79.2%. It's not statistically significant. So sublobar resection for a typical carcinoid can be done for a less than 2 centimeter tumor, where R0 is achievable, but full mediastinal nodal dissection has to be done. So patients with a limited reserve or where a second primary is anticipated, we can do a sublobar resection. An article NCDP database study by Arnani et al. On atypical lung carcinoid, it also surprisingly showed that lobectomy and sublobar resection have similar survival probability. They also compared it between node negative lobectomy and node negative sublobar resections, and node positive on lobectomy and node positive sublobar resection. All of the curves are similar. They also assessed segmentectomy with wedge resection. So among the sublobar resection, both of the surgeries they assessed, and both of them showed similar results. So segmentectomy or wedge, the data does not choose. So it has been almost same all throughout. Even in stage 1 carcinoid, even with the typical carcinoid. So the anatomy still argues for segmentectomy. However, wedge is not disqualified. We can do a wedge resection. It is technically easier. Anatomic segmentectomy is much more technically challenging and technically difficult, especially in minimal invasive techniques. And atypical, if it is present, then sublobar resection, it carries higher locoregional resection. Hence, lobectomy should be performed if it is an atypical histology. And parenchyma sparing resections, we have already sleeve resection. So 82 to 95% 10-year survivals is seen after a complete resection of a typical carcinoid. So the lung that we leave behind, it has to last that long because the person is going to survive. And these patients are usually young. The tumor is slow growing, and the lung that we remove, it is not going to come back. So a sleeve resection costs an anastomosis, but a pneumonectomy costs a lifetime of a reserve. Bronchoscopic treatment is also possible. Who are usually qualified for that? If it is a completely intraluminal tumor, if there is no extension through the cartilaginous wall on the CT, if it's typical histology, and radiologically the nodes are normal. So we can use ND-YAG laser, diathermy or cryotherapy, and it is a repeatable procedure. We can do it step by step or stage wise. What it helps, there is immediate relief of any obstruction. So a collapsed lung might open up. So we get a chance to plan the surgery, and the patient can volume, and we can plan for a sleeve resection later on. So reported survival is compared to bronchial sleeve resections, and it is also used as a debulking option. But what it costs, there is no nodal staging is possible here. There is no specimen that is left for a mitotic count or necrosis. As discussed previously, we need a final specimen, whether it's a typical or atypical, because the follow-up matters according to it. And it commits the patient to repeated bronchoscopic surveillance. So cure is a cure without a stage. We do not know the stage, and it should be reserved for patients who cannot tolerate resection or for tumor that are typical histology and intraluminal. So lobectomy is a default for atypical carcinoid because 17.9% recurrence is seen after radical resection for atypical compared to only 1.8% for carcinoid. It is 74.9% is the 5-year disease-free survival in an atypical carcinoid compared to 97.5% in a typical carcinoid. 15.8% clinically node-negative atypical carcinoids. They're usually upstage. So it may be imaging, it may be node-negative, but after the resection, you might find those 15 points. So we have to do a nodal resection. And in a NCDB study of 669 patients, lobectomy did not significantly improve the OS over any sublobar resection. What happened was the curves were separate within the node negative patients. They did well, regardless of whatever operation was done. While the node positive patients, they did worse. So lobectomy, even if it shows this data shows that sublobar resection is enough for an atypical, because it delivers the nodes reliably, and the node status is what matters. So a peripheral atypical carcinoid, it has a higher chance of recurrence after a sublobar resection, and hence lobectomy is still recommended for an atypical scheme. As discussed, these are the nodal stations usually. So right now, it is not the number of nodes that is important. It is earlier it was said that 10 nodes must be removed. Now it is 6 nodal stations must be removed, and 3 of them must be the mediastinal nodes. So for a right upper lobe or a right middle lobe lobectomy, along with the N1 nodes, that's 10 to 14. So this tumor goes like this. So the subcarinal node has to be removed, and the 10 to 14 in all the lobectomies. Additionally, in a right upper lobe and a right middle lobe, the 2R and 4R must be removed. For a right lower lobe, similarly, 10 to 14 and 7 must be removed, 8 and 9. Similarly, for the left side, station 8 and 9, and 10 to 14 with 7, and 4L, 5, 6 must also be removed along with 7. So nodes are positive more often than what the histology suggests. Upstaging in clinical N0, as discussed, 15.8% in an atypical carcinoid, while it was only 8.4% in a typical carcinoid. So 1 of 9 typical carcinoids is node positive at the time. Atypical, it's 3 times higher, 1 of 3. N2 or N3 disease occurs in 15.3% of an atypical carcinoid. So it is also a high risk tumor. And radiologically normal mediastinum is upstaged in one of 12 typical carcinoids and 1 of 6 atypical carcinoids. So nodal involvement, definitely nodal dissection must be done. There is no justification for skipping a nodal dissection, not small tumors, not peripheral tumors, neither when the biopsy is typical. Node and to whom? So occult nodal upstaging in an atypical carcinoid, the hazard ratio for the risk of death is almost 2.1 for an atypical carcinoid. But for a typical carcinoid, it is not. But any nodal involvement in a typical carcinoid, the risk of death is higher. And it's almost same in an atypical carcinoid. So in an atypical carcinoid, nodal dissection definitely must be done. And the burden beats the counts. The number of nodes, if it is more than 30 nodes removed, it did not improve the overall survival. But a positive, that is the total number of positive nodes divided by the total number of nodes, that percentage should be, if it is more than 13%, the predicted overall survival and cancer-specific survival were dismally low. The same end stage, but different histology. You can compare our N0 disease, 94% 10-year survival for a typical, and atypical it's 83, compared to the N2 disease, 56% for a typical carcinoid, while it's dismal, it's 28% for an atypical carcinoid. So the end stage may mean different thing for different histology. So the basic practice points that I want people to know, that 6 stations must always be removed. They must be mediastinal and subcarinal, which I am repeatedly stating. Ki-67 can be requested, however, it is not mandatory for WHO, but a positive node ratio is important. 13% of positive node ratio, above which the cancer-specific survival, it fell sharply. And more number of nodes does not mean better care. Removal of more than 30 nodes survival, and some guidelines permit sampling, but 8.4% occult upstaging rate is present even in a typical histology. So we never know. So we always go for a node dissection. This is how we perform a thoracotomy. This was the last thoracotomy we performed for a tumor and lower lobe tumor, but the lower lobe was removed, as you can see here. And the incision, you can see it's quite a large incision. It's painful, but due to the PMJY and lack of possibilities of, we have to do these surgery, thoracotomies. Nowadays, minimal invasive surgery is done. It is usually VATS usually has 1 utility port and 3 other ports for the camera and instrument. Robotic surgery usually has 4 ports and 1 assistant port. You can see the vision. Here, it's like working in a whale. It's deep and inside. Here, you can see, so it's such nice. This is a subcarinal node being dissected from this. This is the bronchial. This is tracheal bifurcation. This is a subcarinal node that is dissected out. Here is how the robot looks. And this is now is the era of uniportal surgery. Now uniportal VATS. So you can see with this much small incision, this surgery, immunectomy can be done even if this small incision. So a couple of minutes on the resected LC neck. It's the same. Disease is different. So R0 resection is must. And a sublevel resection is always inferior here. A systematic nodal dissection is non-negotiable. It has to be done and usually within the last 2 years. And adjuvant therapy is started from stage 1B onwards. After the complete resection of a carcinoid, what adjuvant therapy? I'm not the best person to speak about it, but in a typical carcinoid, there is no survival benefit of adjuvant chemo. Our NCDB data series even showed a worse 5 patients, 69.7% with chemotherapy and 81.9% was without. It was surprisingly that chemotherapy led to worse survival. So definitely in typical carcinoid, there is no role of adjuvant chemo. Atypical, there is no demonstrated benefit yet, but in stage 3 disease, 54% survived with chemotherapy versus 46% without. So which is statistically significant. However, NCCN permits giving adjuvant chemo from stage 3 onwards. So follow-up should follow the nodes and not the calendar. A study, it showed that typical carcinoids, it had only a 1.6% recurrence rate, while a atypical carcinoid had 15.6% recurrence rates after 10 years. So according to them, 10-year recurrence rate, since it is so low as per the ENET study, there is no routine follow-up is recommended. However, in node positive typical carcinoid, it's 15.6%. So low dose CT at lengthening intervals should be done. In the atypical carcinoid, the recurrence is 17.9%. So it's regarded, you have to go on with the follow-up, with a regular follow-up, even with the SSTR PET CT. So as per NCCN, in 12 weeks to 12 months post-resection, we can do a history and physical examination. And for functional tumors, biochemical markers and imaging. And 1 year post-resection, we can do continue every 1 to 2 years, we can do an imaging and history and physical examination. As per the European guidelines, they have classified it according to R0 and R1 resection. And accordingly, they have, as you can see on the screen, 1 year for every 2 years for T1, T2. And if T3 or T4 N plus in a typical carcinoid, it's 6 months for 2 years and then every 2 to 3 years. If it's a R1, its frequency decreases, frequency increases. And if it's atypical, the frequency again increases. However, in all cases, gallium-68 PET is recommended. So 5 things I want you to take back to your unit. Let's operate for the histology you may not have. Always plan the resection as though the resection, it could be atypical carcinoid. So parenchyma sparing is a norm. It has to be parenchyma sparing and nodes should not be spared. Nodal dissection is must because no scan rules out an N2 disease. Adjuvant therapy has no role in after a complete typical carcinoid resection, even in a atypical carcinoid. However, the nodal status, it will set up the follow-up. These are my references. I'm open for any questions. And greetings from Sama Hospital to Fulnakra. This is our team here.
So excellent talk, Dr. Pratik. Though you are not a radiation oncologist, there is one question in the chat box whether does bronchoscopy treatment include the intratumoral bronchus brachytherapy in the primary bronchial unresectable net? So it's kind of a vague question. Would you like to answer? Yeah, please.
Bronchoscopy treatment include intratumoral bronch. I don't understand the question actually. Brachytherapy.
Agree. So my point would be here is whether you have to see whether so basically if we go through the guidelines, it is not recommended as intraluminal modality of treatment, but in those kind of unresectable, your intent is important. If you want to relieve the symptoms, if it's very low grade like grade 1, then the stenting is definitely a fair option because in that case, the grade 1 is going to grow very slowly and patient is going to have a years. But in the brachytherapy, you need expertise and because rarity of this tumor, evidence strength is not high. That is what I would like to answer. You want to say something?
I want to add a couple of things. Bronchoscopy treatment, it is not a care. We usually reserve it for either debulking the patient so that the lung function improves so that we can operate on the patient and temporarily. And if in a second case is if the patient's performance status is very low so that he will not tolerate anesthesia. So only then we can do a bronchoscopic resection. That is what my take home message was, I think.
Agree. Thank you, Dr. Pratik.
Thank you, Bhushan.
Thank you. I would like to invite Dr. Shruti Gohel, our dear friend, colleague from Shelby Hospital, Surat, regarding her talk on the playing the right cards, strategic sequencing and the advanced nets. Welcome, Dr. Shruti.
Thank you so much, sir. I'm very grateful to you for this opportunity, and I'm also very grateful to IAIO for having such a great program. It's actually a very great learning even for the speakers. So I learned a great deal from my previous speaker. I will jump directly to the systemic and the other treatment and how we should be sequencing them. Is my screen visible?
No, ma'am, not yet.
Okay. Actually, I requested for sharing my screen. Can you share the screen from your end? If that
Yes,
is
yes, sure.
My browser is preventing. Okay. Yes. Okay. So we go to the next slide, please. As we all know, our choice will be dependent first on the histology, which Sanjay sir very nicely taught us. We need to differentiate between NET and NEC. Also, Ki67 plays very important role. Also, Dr. Pratik very nicely mentioned about the anatomical part of it, where it is feasible to do surgery. Very important consideration is whether we will be able to have R0 resection or not. So if the tumor is going into pleura or in pericardium, it becomes very difficult to have R0 resection. So we will talk about what should we be doing if we have R1 or R2 resection, what should be the adjuvant therapy. Another important consideration is SSTR uptake, which very nicely was taught by Dr. Akshay. Another important aspect is we need to identify Cushing syndrome and carcinoid syndrome early on, very nicely taught to us by Dr. Savinay. So we go to next slide, please. What do we do if we, next slide, please. What do we do if we have a patient, next slide, where we have R1 resection? So if we have next slide, please, R0 resection, then no adjuvant therapy is required. Next slide. But if we have an R1 resection and if we have it as a typical carcinoid and stage 1, and if the patient is asymptomatic, again, no adjuvant therapy is required and we just opt for observation. But if we have a high-risk patient, meaning if we have a patient who has atypical carcinoid, or if a patient has bulky nodal disease or severe Cushing syndrome, then we actually opt for re-intervention. If re-intervention is not feasible, or if patient is unfit for surgery upfront, then SBRT is a consideration, though it is not standard of care. And if that cannot also be an option, then in cases of high burden disease, especially N2 disease, atypical carcinoid, and the ones with high Ki67 index, we opt for adjuvant chemotherapy. The chemotherapies are usually platinum or alkylating agent based regimen, which I will talk about in a little while. Next slide, please. Let's talk about how do we manage Cushing syndrome and carcinoid syndrome. So we need to actually screen for and identify Cushing syndrome. Then we need to characterize it in terms of anatomy, whether it is a localized disease or metastatic disease, and how severe is the burden. So if we have a patient presenting to us with Cushing syndrome, and if it has a localized disease and the symptoms are not severe, then we go for upfront surgery. But if the symptoms are severe, then what we do is we first use steroid synthesis inhibitors, and we use the doses in titration, and then after several months, we plan a delayed surgery. So what are the steroid synthesis inhibitors we use? The agent of choice is metyrapon because it has rapid onset. Also, unlike ketoconazole, it does not have much of drug-drug interaction. In selective cases, we can also use osilodrostate. If patient requires ICU and in acute crisis, we also go for ethomidate. So these are the agents that we use. Now, if we have a patient presenting to us with Cushing syndrome, and if patient has metastatic disease, if the symptoms are not very severe, then we go for all the steroid synthesis inhibitors. But if the symptoms are very severe, then we go for high dose of these medicines upfront. So titration means we begin with lower dose and then we go to higher dose as and when required. But if we have metastatic disease with severe burden, we directly go for higher doses. In some of the severe cases, if the symptoms are not getting controlled by the systemic therapy, and if the patient is moving towards like severe heart disease kind of picture, then we can also intervene by doing early bilateral adrenalectomy. Also, when we are giving all this treatment, again, our heart is very, we need to have early involvement of cardiologists, not just to look for the symptoms, whether it is going towards the heart disease side, but also to monitor the side effects of the medicine. Especially, we need to monitor QTC prolongation. Next slide, please. coming to how should we be managing carcinoid syndrome here, the trigger where we should consider giving treatment is when urinary 5-HIAA levels are more than 2 times the upper limit of normal. So the first line therapy is somatostatin analogs. We generally use octreotide LAR or lanreotide autogel in standard dose, and we maintain them for life. The standard dose for octreotide is 30 mg every 28 days, and the standard dose for lanreotide autogel is 120 mg every 28 days. If the disease is refractory, meaning that if the patient has persistent diarrhea, defined as being more than 3 loose stools per day, or if patient continues to have flushing, which is affecting his or her quality of life, or if the 5-HIAA levels are more than 3 to 5 times the upper limit of normal, then we go for the second line of treatment. Here the options are, we can increase the dose of SSA, like octreotide usual dose is 30 mg, we can increase it to 60 mg, or we can use other agents like pasireotide or telotristate ethyl, which are peripheral tryptophan hydroxylase inhibitor. We can also use locoregional therapy depending on what the symptoms are. If still not controlled by this, and if we have a very high burden disease, we can go for third line therapy. If the patient has SRI positive disease, then the choice would be PRRT by using lutetium 177 dotatate. In certain selective cases, we can also use interferon. Please, next slide, please. We should be mindful about the exacerbation of our the symptoms when we use PRRT. But if we carefully manage it, then that initial phase is managed with a good counseling and with good monitoring. And once that phase passes, the patient actually has good response to PRRT if it is SSTR positive. Now, talking about systemic therapy for advanced disease or if patients have a metastatic disease, just like Dr. Karan very nicely pointed out, that just like any other disease, we also have concept of oligo metastasis and oligo progression. How relevant it is in this particular group of diseases, very difficult to say, because it's very rare, like we rarely come across such this particular entity. Also, there are not very established studies which give us answers in black and white. But just like we apply usual concepts, if we have oligometastatic disease, we should tackle it that way, just like we are doing anywhere else. Or if we have oligo progression, then we should introduce locoregional therapy as and when required, along with the other therapy that we are doing. So again, how do we approach advanced disease and the systemic therapy for them? So if we have a typical carcinoid which is slowly progressing, then and patient does not have patient is completely asymptomatic, wait and watch is fairly nice strategy. We will also or we can start SSA at standard dose. If we are using if we are opting for wait and watch in first line, and if patient progresses on it, we can introduce SSA in the second line, and as and when required, we can use locoregional therapy. If not managed with it, we can use high dose of SSA in third line, or we can also use pasireotide. Talking about management of atypical carcinoid or those typical carcinoid which is rapidly progressing disease, we can divide them in two subgroups. One is low tumor burden and high tumor burden. So if we have low tumor burden and our goal is more about disease stabilization and maintaining quality of life, then our the choice of drug for first line would be everolimus based on variant trial. The second line would be cabozantinib, which is the only FDA approved multikinase inhibitor based on cabinet study. Exitinib has also been studied, but it's not FDA approved. Talking about third line therapy, how do we decide between PRRT versus chemotherapy? So if we have SSTR positive disease, then we should opt for PRRT. And if not, then chemotherapy would be choice. Or if for any reason PRRT is not available, then chemotherapy would be the choice. How do we decide which chemotherapy regimen should we be opting for? So we do MGM testing here. If MGMT is deficient, then temozolomide chemotherapy-based regimen is preferred, like CAPTEM regimen. If it is proficient or if it is unknown, then oxaliplatin-based regimen is preferred, like Capox, Folfox, or Gemox. Again, coming to how do we manage atypical carcinoid or typical carcinoid with rapidly progressive disease with high tumor burden, where we want rapid debulking of disease so that we can have faster symptom control. Here we can actually go for we can use the more aggressive therapies, which are PRRT or chemotherapy. If not control on them, then we can go for target therapy like everolimus or cabozantinib. Now the question comes is, do we routinely do NGS testing for such patients? So our commonly the druggable targets like NTRK, RET, they are not they are very rarely found. So almost like they are not found. So it's not NGS testing is not routinely suggested. Question comes whether immunotherapy would be working on NET. So immunotherapy, single agent and dual agent, both have not been found to work on them. There has been some positive signal with spartalizumab, especially in the selected groups where they had patients with PDL1 more than 10 or a TMB more than 10 or ARID1A genomic mutation. But these are all investigational studies. But at least we should look for tissue agnostic biomarkers, which are MSI high and TMB more than 10. So if we find one of them, then definitely pembrolizumab and dostarlimab accordingly is a choice. But again, these two findings are very rare. Next slide, please. So summarizing, if we have a very indolent kind of presentation, wait and watch is a good strategy. Then, or we can start with standard dose SSA. If not controlled on that, we can either increase the dose or we can go for other agents like pasireotide or tilotristide ethyl. If not controlled on them, we can go for targeted therapy like everolimus and cabozantinib in that sequence. And if not, if we want aggressive management, then based on SSTR uptake, we can choose between PRRT versus chemotherapy. And the choice of chemotherapy is based on MGMT testing. Based on that, we can use temozolomide-based regimen or oxaliplatin-based regimen. And not to forget tumor agnostic approvals for MSI high and TMB high. And wherever applicable, we should go for pembrolizumab-based regimen. So that's all from my side. Thank you so much.
Thank you, Dr. Shruti, for your elaborative, crisp and clear presentations. We definitely come to know the current landscape of management and how to sequence them. I request all of my speakers, if they are available, the next would be the one case discussion, which actually we have faced in our real world practice. I'm going to share it. I would like to welcome all of my panelists, Dr. Vedant Modi, my dear friend and colleague from the Medical College Jabalpur and State Cancer Institute, Dr. Aditya from HCG Cancer Vadodara, Dr. Udipatya from Tiruvananthapuram, Dr. Keval from Rajkot Cancer Society, Nathal Cancer Parikh Institute from Rajkot, Dr. Vishal from Karansad Medical College, Dr. Avinash from Bhubaneswar, and Dr. Susmita from TMC Kolkata. I'm going to share my screen here. I also welcome all of speakers if they are there. Stay back. Please provide your inputs, how we manage this patient. Your comments and your expertise definitely would help us to give us more insight. So my screen visible, Subhashri? Is it
Yes, sir,
moving?
visible.
Yeah.
Visible. Yes,
So
sir, moving.
today we are going to discuss a case-based panel discussions. For all attendees, till now we have discussed all theoretical parts. This would be the real-world case discussion. So without wasting much time, I will start. So 64-year-old male, farmer by occupation. He's a resident from Jaipur, and only hypertensive, which is well managed on the antihypertensive medications. No habits, no major surgery, no significant family history. He was evaluated for lower limb pain and lower backache for 1.5 months. There were no constitutional symptoms, and This patient's son is our own ortho-onco fellow, not ortho-onco, but ortho fellow. So MRI spine was done by the orthopedic department, and it was revealed that there was a ill-defined sclerotic lesions in the right iliac bone with the cortical erosions. And on screening spine, they picked up there is some right upper lobe soft tissue density mass lesion with spiculated margins. So CT thorax was done, which revealed that around 3 centimeters soft tissue density mass lesion with spiculated margin is there in the right middle lobe. And there is one node, 15 to 20 millimeter right hilar node, and the radiologist reported primary malignant lung lesion. With this background, these patients come to us. So we did the PET CT scan, which the findings are described here. So basically, again, FDG with pulmonary lesions. You need to note the SUVmax of 8.1 here, which was there in the right upper and middle lobe. There was one low-grade FDG with mediastinal node, subcarinal right paratracheal and right hilar. SUVmax was 5.2. And then there is right iliac lesion, SUVmax was 4.9. There is one right parafalcian extra-axial lesions. They mentioned likely meningioma. And there is one another parieto-occipital lesion with surrounding edema, mentioned as probably METS, probably infective or inflammatory lesion. And there is surrounding edema. With this, the patient was referred to a medical oncology department. So my question is to my dear friend and colleague, Dr. Vedant, how would you have proceed with this much information?
Okay, so in this case, adenocarcinoma multiple study is declared.
So basically, we did a CT guided biopsy, and the radiologist on biopsy, they have mentioned this one that there is probability of non-small cell carcinoma, adenocarcinoma is favored. However, the report of IHC-TTF1, synaptophysin, ALK, and PD-L1 will follow. So usually at our institute, my protocol is if it is adenocarcinoma, I ask them to give me ALK as well as PD-L1 so we can start some treatment. So this is their impressions. Yeah.
So if we take this based on what our topic is, I would like to have the mitotic and necrosis also to mention to rule out whether it is going towards neuroendocrine tumor / carcinoma versus the epithelial malignancy, which is like squamous or adenomatous in this case.
Agree. So basically, we did a IHC, and surprisingly, this is the IHC report. They are basically positive for TTF1, synaptophysin, chromogranin, and negative for P40. And Ki67 proliferation rate was 12 to 14%. And the final report, the pathologist mentioned is that it seems that it is a atypical carcinoid, considering the radiology as well as the PET CT finding. So meanwhile, during this workup, he had left lower limb focal involuntary jerky movement, so kind of a focal seizures. With that background, we did the MRI brain, and definitely there were 2 lesions in the brain. So to see them also, we did a MRI brain, and here is the finding of MRI spine as well as the brain. In spine, they have mentioned that there was one 3 into 2 into 4.1 centimeter lesions of right sacroiliac joint, cortical erosion, soft tissue density lesions, and on MRI. So with this background, would you like to do anything else, Dr. Vedant?
I would like to, since it is proven that it is atypical carcinoma, I like to go for SSTR-based study, which is like DOTA knock or DOTA TATE, gallium DOTA knock / DOTA TATE PET CT scan.
Yeah, so we did the same, and you are seeing the images. This possibly is the parafalcian region they have mentioned as probably meningioma, but this is the internal necrotic with ream enhancement and low lesions, probably METS. And this was the primary, and there were some nodes, definitely parahilar and subcarinal, and this is the right iliac bone lesions. So Aditya, what's your impression would be after having this clinical background with workup?
Good evening. So, the Dotanok PET CT, it suggests that there is a primary lung lesion with, I think, bone and brain metastasis. So, in the workup, I think chromogranin levels are missing. So, we can advise a chromogranin baseline level, after which we can take a radiation oncologist opinion, as we have a MRI brain with us. So, either to give the RT2 brain or not, as well as bone, if there is painful bony metastasis.
Agree. And before we jump on to the next slide, let me ask all of you, how would be the frequency of lung NET in your OPD? How frequently you see? Well, let's start from Dr. Vedant and then move on to the other panelists.
So maybe like in a month, two or three cases in a month.
That's good number. Aditya?
Very rare, like one
Yeah,
in
so
3 months or 6 months.
I'm asking about, yeah, exactly. So 1 or 2 cases a year in my area where I am practicing, western part of India. Then Keval?
Yeah, around 1 or 2 maximum because of the load, I suppose. Once
Yeah.
in a month, I
So
guess.
just
Yes. Udipatya?
I think I have seen only 2 or 3 cases
so
in my small
because
career.
my OPD I'm working.
Yeah, Vedant.
So my center is government center. We have like 15 to 16 new OPDs every day, new patients. In that, in a month, maybe like 2 or 3 cases is reported.
Okay. And what about Vishal and then Dr. Sushmita is there? How frequently you see this pulmonary NET?
Yes, in last 6 months, I have seen two pulmonary NET cases.
Good. And Dr. Sushmita?
Yeah, I mean, grade 1 and grade 2 NET is rare for me. Neuroendocrine carcinoma or atypical, sometimes I have seen neuroendocrine carcinoma variety, but proper like typical or typical carcinoid is rare, only 1 or 2 cases only.
Thank you. So with this, let me ask Dr. Udipatya. So we have one lesion. There is focal involuntary movements of the leg in last few days. There was surrounding edema. How would you like to address that brain lesion?
I think the brain lesion, if I'm not wrong, was something around 2 to 2.5 centimeter, around that.
Yeah.
And now that he has symptoms, I would rather take a radiation oncology opinion and subject him to a SRS. That would be a better idea. But then I don't think there is any defined guideline to decide between SRS and surgery. But then anything larger, more than 3 centimeter, we would be more tending towards a surgery. If that's just a soft indication, I feel. That is one, and obviously not a whole brain RT in this case. A single lesion to 2.3 centimeter, SRS would do good. And I think a regimen of 24 gray in 3 fraction is what nowadays people are routinely using, alternative day. So Tuesday, Thursday, Saturday, or something like that. 24 gray in 3 fractions. I think that would be a good idea from my end.
Right. So any panelist here would like to defer their opinion here? So we basically did a radiation oncology opinion, did a SRT to brain lesion, 24 gray in 3 fractions and 1.5 weeks. And because he was presented initially with the lower backache and the symptoms, my radiation oncologist also did the RT to the iliac bone. So let me question Dr. Keval. So the local part is over. What about systemic treatment, and what are the factors you would like to consider in your day-to-day OPD for such a case where you have to plan the
So
treatment?
yes, surely the symptoms first. Secondly is the histopath that we have seen. And along with LAR, as per the latest trials, I can add everolimus 10 mg once a day.
Right. Very good. So basically, we also started LAR 30 mg and monthly doses. And I would like to come to this question to of everolimus dosage. So we started on 5 mg daily, and with that, let me ask again either Udipatya or Keval, you can answer my question. then if so once you start the everolimus, what would be your frequency of first follow-up? Because right now in this case I'm going to discuss the practical real world scenario which we are doing in day-to-day OPD.
So with everolimus, I usually start with 2 weekly follow-up to see
Yeah,
CBC as well as fasting
great,
glucose and triglyceride level monthly.
perfect. So first follow-up should be at least on the 2 week, right? All of us agree, I think. Yeah. So my first follow-up was on the 2 week, and then we did so basically one thing
One more point, Pushpendra sir,
yeah,
I would
please.
like just want to add this that with everolimus, obviously he will be prone to multiple infections. His
Agree.
mTOR pathway will be blocked. So I would be also inclined to, before starting everolimus, to give him all the vaccines that are available. So the Influvac Tetra vaccine as well as the Pneumovar 23 vaccine. And since he's not a diabetic, we can get away with the shingles vaccine, but overall, I would like to give the vaccines also to him before starting everolimus.
Excellent, excellent point. I would like to ask all of you panelists here, what the everolimus dosage you start with in your patients? I mean, from Aditya, Vedant, Vishal, Dr. Sushmita, one by one, if you can answer.
So 5 mg OD and then
Yeah, Aditya?
5 mg daily. Yes.
Okay, okay. Vishal?
and then maybe
Yes,
have to
5
stop or
mg initially. If tolerate well, then escalate the dose.
And Udipatya?
Sir, I would be happy with 5 mg, starting with a low.
Right. So, so patient tolerating it well. Only thing his son used to send me is the higher glycemic side. So usually I subject him to say to visit the endocrinologist or MD physician for appropriate glycemic control and monitoring. Now, after 2.5 months, he visited. He had a symptoms of fever and at a local place, hyperglycemia. So he was managed there for 5 days nearby Jaipur, and then there was no relief. So I asked them to visit us. On our presentation, he has anemia grade 2, neutropenia grade 2, and the rest biochemistry were well within the normal limit. So we admitted him. So pyrox of unknown origin for 7 days on broad spectrometry, not getting relieved. But definitely it was Zostem and those kind of antibiotics. So one important point which I have not mentioned here is there was a typical one symptom. When he got the steroid, there was no fever for 24 to 36 hours, right? But once the patient is off the steroid, he again has a persistent fever. So we admitted him, started on broad spectrum antibiotic, hyperglycemia management, IV fluid, stopped everolimus, sent the blood CS, procalcitonin, urine RM, and we did initially CT thorax and USG abdomen to find if there is any infective foci. Procalcitonin was mildly raised, not clinically significant. Blood CS was negative. After 3 to 4 days, again having a persistent fever. So we did the ID consultation reference, and he suggested FDG PET to rule out the infective foci. Now, I was not in a favor to do a too early FDG PET, but because his intention was different, we did it, and I am showing you. By day 5, we also sent the serum beta D glucan and the galactoman. And this is the FDG PET. So if you can see, there are some new subsolid nodules in the right lung. There were some pleural effusions, pleural thickening. And if you can see FDG, there is a lit up of the lesion as well as increased FDG uptake of the mediastinal node. And if you can see those who are the irradiated lesions, especially pelvic, there was no activity at all and they have subsided. So this was the BDG, which was mildly increased. Serum beta galactoman was the 4 times upper normal limit. So at this point, I would like to ask my colleague, Dr. Vishal, what's your impression? What is going on here? Because in day-to-day practice, we have to counsel the patients also, and especially when their son is doctor.
So typically the patient presented with a neutropenia. We have sent the CS and all the bacterial or rule out the foci of the infection. So we didn't find any foci of the infection here. and blood CS come up negative and persistent fever spike for more than 5 days despite of the spectrum antibiotic. And the rightly we have sent the fungal marker, galactomannan and beta-D-glucan. So if the guideline says if a patient have a persistent neutropenia for more than 5 to 7 days, and the fever spike is not subside with antibiotics, so we can empirically start the antifungal prior start antifungal, we can send the fungal marker and also go for the HRCT test to look for the invasive fungal infection in the lung.
Right. So similarly, my ID consultant, I had a discussion whether we can take that small amount of pleural fluid, whether it can be useful. But he said then there is yield would be doubtful, and we started on the voriconazole as per his suggestions, and there was a defervescence within the 48 hours. So we plan to discharge, and on day 5, he has again nausea, vomiting, lack of appetite, but there was no fever and fatigue. So he is there in the OPD with SGPT 10 times upper normal limit, alkaline phosphate is 5 times upper normal limit, and bilirubin 3 times upper normal limit. With this background, again, we did a gastrology reference. And his opinion was it is probably the drug-induced liver injury, and it is the culprit is the voriconazole. Would you like to add anything here, Dr. Vishal?
Yeah, because as per our patient history, he or she doesn't having any liver mets, and we are on antibiotic and antifungal. And during the course, the liver marker and liver profile will be rearranged. So typically, we are thinking about anything drug-induced liver injury here only, not for any disease progression or anything else. So typically, before the patient is already on antibiotic, but the liver derangement not there. But after voriconazole is typical notorious for the liver toxicity. So in my practice, if I start the patient on a voriconazole and patient is admitted, so twice a weekly, definitely I will go look for the SGPT and bilirubin for patient who are on a voriconazole initial 2 weeks. If patient is settled in 2 weeks, then after we can gap for the testing for the liver profile.
Right. So we switched on to the isavuconazole, and again called him after 3 days. So on day 8, all were there in the downtrend, and we continued the isavuconazole, stopped the antibacterials apart from antifungals, and called him after follow-up of 1 week. So here I would like to ask my colleague Dr. Keval or Aditya, what do you think about the role of MDT and inclusion of other specialty in a situation like this? How they are helpful beyond what we know as a medical oncologist? Short and crisp comment from both of you, please.
Yeah, so combination or MDT is very important to have a broad view about the infections which we are not considering. So right now, if I can see, the only thing that is striking my mind is PJP infection. I need to ask you, what was the O2 level and was it breathless or not? Have you done bronch or not? Something like that.
Very good question. So on admissions, his LFT was normal, no hypoxia, no tachypnea. Thoroughly the admissions of 4 or 5 days, his respiratory status was very well within the normal limit. My ID consultant said that he definitely had a second doubt of this one, PJP. And anyway, patient is on the prophylaxis with hyperglycemia on Bactrim DS, one alternate day. So even I had discussed with my ID consultant whether should I do it like a curative dosage from the prophylactic dosage. He asked me after 2 or 3 days of antifungal, if patient is not responding, then we will do the bronchoscopy, BAL, and then thorough workup. But before that, we got a response. Yeah. Aditya, anything you would like to add?
No, not really. Let's see, in daily medical oncology practice, it is always teamwork. So we need gastroenterologists, we need nephrologists to look for the drugs which we are prescribing, whether there is whether the create clearance is okay or not. So it is always teamwork.
Very good. So after 2 week follow-up, patient was asymptomatic with improvement all labs, back to routine normal limits. So my question is, Dr. Abhinash, what to do now? Re-challenge everolimus, and what's your thought on the other agents?
So, good evening, Pushpin Bhai, and all the panelists. So first of all, the patient had no comorbidity. Patient,
Hypertensive, very well managed to start with.
yeah, no other comorbidity like diabetes mellitus. So the hyperglycemia and the neutropenia, they are due to the everolimus, as we know. And now, to whether to re-challenge the drug when the patient had an invasive fungal infection, it is a difficult question. We have started with a lower dosage upfront, 5 mg, which we usually do in our clinic. Now, there is a guideline we can switch to 2.5 mg OD also. But I think the patients and relatives will be skeptical at this point to use that drug. If we say because of the drug, the adverse effects have happened. So I would also be skeptical to use the drug again, depending on the course the patient has followed with, admission for neutropenia and hyperglycemia and fungal infection. So I would like to switch to other agents. There is one option we can give LAR only, but the patient has brain metastasis, and LAR doesn't have that penetration to brain. I would like to keep one drug which penetrates the brain at this point of time. So the best options will be temozolomide, because as we know, temozolomide excellently penetrates the brain. So Captem is a good approach, temozolomide with or without capecitabine. And also cabozantinib has also 20% brain penetration. So both these options should be kept in mind. And I would try to avoid everolimus and also single LAR.
Right. So basically, there was a mismatch between the FDG PET as well as the DOTA, which we did in the baseline. So that was only, and anyway, Chi60 was 12 to 16%. There were two metastases. One is the brain, one another is the bone. So LAR alone, I was a bit hesitant. I didn't do it. And at this point of time, we discuss patient and relative about the Captem because of, as you mentioned, the higher brain penetrations. And if few of my colleagues remember, I have discussed same case in our one of close group in the WhatsApp, and they have mentioned that Captem. So I discussed the Captem. But his son again has a fear of chemotherapy and what happened with the everolimus. They want some oral. Definitely, I have explained about the side effects and toxicity profile of Cabo also. But anyway, we started with cabozantinib 40 mg OD, May 2024. First follow-up again 2 weeks. Dr. Susmita, your inputs when you start the cabozantinib in daily OPD, what's your routine doses, what you are looking for, what toxicities you are vigilant for, and what would be in this NET case when you would plan the next scan?
Hello, am I audible?
Yeah, please.
Yeah, so usually in my experience, cabozantinib, I start with the 40 mg, 20 mg dose usually. 40 mg is not well tolerated, and the HFS is one of HFSR is one of the problematic scenario. So I usually monitor, even if I start with any TKI mostly, which has a little bit of kind of side effect profile. So I usually ask for the 2 weeks, first 2 weeks with the 20 mg, with the 2 weeks with the routine blood, as well as I also do the baseline, also like, TSH, thyroid profile and all those things as well. And also, if it is a normal, then I usually repeat after 4 weeks only the other things and the routine blood. And I ask them to come back, stop the medications and come back to us if she or he is experiencing these typical hand, foot, and reactions or any kind of diarrhea, and ask them to come to visit clinic before even 2 weeks also. Otherwise, routine visit is on 2 weeks. And regarding the first response scans after starting on cabozantinib or any other kind of TKI, then usually it is slow. We are not expecting very huge response, very like a chemotherapy we are giving here. So usually not before 4 months, and preferably 4 to 6 months only I do, 4 months.
So what? So exactly what we did, what you have mentioned, and patient has tolerated till now well. The only question was because of the mismatch between the FDG as well as SSTR uptake, and the last time we could only do the FDG. We called him after 2.5 months of starting cabozantinib and did the SSTR Dotanok just last month. And these are the images. So basically, the lower panel is the previous one, and the upper panel is the current one. if you can see, there is a very good response where they have
Yeah.
irradiated with the focal radiotherapy. But not only that, even those sites which initially are having a uptake, the uptake has been reduced significantly, except this node, one which is the
Sorry to interrupt. This was with 20 mg cabozantinib for 40 mg. This is
40
20.
mg.
40
40
mg.
mg. 40 mg and probably 80-90 days after starting the cabozantinib in the July, after 2.5 months. So, but patient is totally asymptomatic, no symptoms from this node. It was just increase in the uptake of SSTR PET. With this, we just continued, we recounseled, and we said that, yeah, let us continue the same. And if there is any symptoms, we would like to see him again at the OPT. I called him after 2 months, not plan after any scan. So I would like to ask Dr. Vedant, Dr. Aditya, and all of my panelists one by one. What do you think? Any role of CGP or limited panel NGS here?
So NGS maybe for future target if we can find. Otherwise, there is none much. As Dr. Shruti had said in previously that there is no much role of NGS because it is not target rich area to begin with.
Yeah. Aditya? Is Aditya here? Keval?
Yeah, so even if you want to send NGS, I would suggest a rebiopsy because
Agree.
there's
So,
a deeper, yeah.
yeah, so basically the point would be ki you do it when you have exhausted your options, because at that time tumor biology may have evolution and they may have a new clone, which would be more insightful to know. Any panel would like to differ here or provide their inputs?
I just had one discussion with
Yeah,
everyone. I think it's rather a question from my end. Is that if we do a rebiopsy, as Keval mentioned, and we now have for example, a small cell differentiation, in that case, would you be okay to add a serplulimab in this setting? Because now we have drug to target that. So what's everyone's opinion? Because I have a recent patient who is not exactly a large cell NEC, but a NEC who has become small cell. So what's your opinion on that actually?
So, Udipta, I'll add something to that. So any of your, modified or transformed small cells very poorly, respond to immunotherapy. So if it's a de novo small cell or it's a de novo NET, then these are actually better. But if it's a transformed, then you'll have a very, very poor response. And I think one experience which I would like to share for the NGS was that I had 2 patients who, had NTRK, and one we gave larotrectinib, and that patient had a wonderful response. So I think role of NGS in the relapse refractory setting is pretty good. So not, 20 to 30% you will find some mutation, but out of that also around 5 to 10% would only be, targetable.
excellent, sir. So basically, yeah, so transform HCLC everywhere. It is prostate or anything else, cervix. There, though they are the limited number of data, IO doesn't help much. And what we did in this patient, because his son is a doctor, as Dr. Karan said, I was vouching for NTRK and TMB. So I explained them whether we can send it or not, but unfortunately we have a scarcity of the tissue, so it couldn't be done. And now we are not doing anything else. We would like to do a biopsy in future if it is transformed or becomes the aggressive one. With this, I would like to, before my conclusion, this is my conclusion, is there on the slide, but let me have one comment from each panelist. Have you managed it differently? Point number 1, or as Udipatya said, to do the vaccinations, which I will definitely consider a valuable input. Anything from speakers or panelists before we conclude? Vedant, Aditya, Keval, Vishal, Avinash, and Dr. Susmita.
Pretty much same. Just I would have started everolimus at 10 mg and would have
Yeah.
got the side effect a bit earlier than you.
Right. And Udipatya or Vedant or Aditya or Vishal.
More or less opinion will be same.
Right. And I would urge all attendees to put their comments, whether this kind of clinical case discussion helps them after the theoretical discussion. With this, I would like to conclude. I thank all my panelists and I thank IAIO for giving this opportunity to discuss this rare tumors. I definitely thank Dr. Karan, Dr. Shruti, Dr. Savinay, Akshay, and all my panelists because this is kind of a rare tumor and definitely would like to discuss. So that what we have tried to do. With this, I would like to conclude my panel discussions and we would like to move on to the one talk by Dr. Chatterjee regarding the management of metastatic NSCLC. Thank you.
Thank you, sir. We now move to our final scientific presentation of the day. It's my pleasure to invite Dr. Anna Bhattacharjee, Consultant Medical Oncologist, Tata Medical Center, Kolkata. Over to you, sir.
So thank you very much to the IAIO team and this wonderful panel discussion just before my talk. So without further delay, we'll start the discussion and allow me to upload the slide. I hope the
Sure,
slide is visible.
Yes, sir. Visible.
So it's a sponsored talk by Dr. Reddy's team. So we will see the management of metastatic NSCLC with special role on bevacizumab, especially in the era of immunotherapy. So the context will be on two aspects: bevacizumab in non-squamous NSCLC and bevacizumab in EGFR mutated NSCLC. So we know that VEGF is a key mediator of angiogenesis. In cancer cells, the environmental factors like hypoxia, altered pH, secretion of different growth factors like EGF, interleukin-1 alpha, IGF-1, all increases, and thereby there is increased production of the VEGF level, causing endothelial cell activation, proliferation, migration, and specifically the angiogenesis as a whole. If we see the microvascular density level, if it is high, the survival is poor. Likewise, the VEGF level high, if it is there, then survival is poor. Now, we'll see the bevacizumab in non-squamous NSCLC. So this was a famous ECOG 4599 trial. It's a quite old trial. Paclitaxel carboplatin alone or with combination with bevacizumab for NSCLC patients. So stage 3B or 4 NSCLC patients inoperable. So these patients were randomized paclicarbo versus paclicarbo-bev. The bev dose was 15 milligram per kg 3 weekly and 6 cycles were allowed. So these were the baseline parameters. We can see around 3/4 of the patients were stage 4 disease. So this is the overall survival. We can see that was a primary endpoint. So 12.3 months versus 10.3 months in favor of the bevacizumab with a significant improvement in OS. Likewise, the PFS also 6.2 months versus 4.5 months in favor of the bevacizumab with a good hazard ratio. So most of the subgroups have shown benefit in favor of the bevacizumab, addition of bevacizumab in terms of overall survival. Regarding toxicity, so there was more incidence of bevacizumab-related toxicities like hypertension, proteinuria, bleeding side effects, but most of the times it is manageable. Now coming to the next trial, it is a point break trial. So here previously untreated stage 3B and 4 NSCL non-squamous NSCLC patients, around 900 patients were included, and they were randomized PEM-carbo-bev versus paclicarbo-bev. So here also bevacizumab 50 milligram per kg dose was used, and in the PEM-carbo arm, pemetrexed plus bevacizumab was given as a maintenance, and in paclicarbo-bev arm, only bevacizumab was given as a maintenance. So these were the baseline parameters. Again, we can see most of the patients were stage 4. Adeno-CA was the commonest histology. So this is the OS results. There was hardly any benefit in terms of the OS in any of the arms. In terms of the PFS, there was some benefit, but although it is not significant in maintenance PEM-carbo arm, PEM-BEV arm. Regarding toxicity, we can see a differential toxicity profile. With paclitaxel-BEV arm, there is a more incidence of grade 3 or more neutropenia, whereas pemetrexed-based arm, there are more incidence of anemia as well as thrombocytopenia, and also more sensory neuropathy as expected was in the paclitaxel-BEV arm. Although PFS was significantly improved with PEM-carbo-BEV, but no survival advantage was observed for paclitaxel-BEV arm against the paclitaxel-BEV arm. So, PEM-carbo-BEV, although is the standard treatment followed by PEM-BEV maintenance, but paclitaxel-BEV is also an useful alternative, especially if we are considering the toxicity profile is a concern. Now, this is in a nutshell of different trials. We can see as a grossly ADS, SAIL, E4599 and AVAIL study, 7.5 milligram per kg and 15 milligram per kg. So the median PFS varies between 6 to 8 months, and median OS is roughly around 1 year. And if we see the objective response rate, it is somewhere between 30 to 50%, it varies. And if we see the meta-analysis of all these trials, there is a definite benefit in terms of the OS with addition of the bevacizumab arm. So bevacizumab we commonly used, and where the TKI is not an option, and even in the era of the immunotherapy, when the cost of the immunotherapy is still higher. Now coming to the role of bevacizumab in EGFR mutated NSCLC patients. So we will see these studies, some real world study, NEG 0026 trial and Beverly trial. So this was a real world study from China. 165 patients were taken. EGFR exon 20 inserted NSCLC patients receiving chemotherapy plus bevacizumab or TKIs or chemo alone. So there was a PFS improvement with second line onwards with the addition of the bevacizumab. But in the first line, there was a no statistical benefit was not seen. Now coming to NEG 026 trial, erlotinib plus bev versus erlotinib in patients with EGFR mutated advanced NSCLC, non-squamous NSCLC. So it was a phase 3 study. Chemotherapy naive patients, stage 3B and 4 patients were taken. Exon 19 deletion and exon 21 L858R patients were included. However, T790M patients were excluded. So these patients were randomized bevacizumab erlotinib versus erlotinib. Bevacizumab here also 150 mg per 50 milligram per kg 3 weekly dose was used. So the PFS, there was a significant improvement we can see in favor of the erlotinib plus bevacizumab, 16.9 months median PFS versus 13.3 months. If we particularly see OS, exon 19 deletion, there was hardly any difference. Exon 21, although there was not statistically significant, but they trend towards improvement of the median OS in terms of addition of the bevacizumab arm. Now coming to the Beverly trial, bevacizumab plus erlotinib versus erlotinib in the first line treatment of EGFR mutated non-squamous NSCLC. So around 80 patients included in each arm, and stage 3B and 4 patients were taken with activating EGFR mutation. Here also, bev and erlotinib, same doses were used. So if you see the median PFS, it was significantly improved in favor of the bevacizumab arm. We can see for BICR groups, we can see the median PFS 14.8 months versus 9.6 months in favor of the bevacizumab arm. In terms of OS, there was a there was a not significant benefit. However, there was a numerical benefit, 33.3 months versus 22.8 months in favor of the bevacizumab arm. And one important thing for former or current smoker also, there was some benefit of usage of addition of the bevacizumab arm. Regarding toxicity, we know that bevacizumab and allotinib both have class side effects, but still with addition of these two agents, there are more incidences of hypertension and rash compared to the allotinib alone arm. So I think we have come to the conclusion slide. So non-squamous mutation negative NSCLC patients, we have enough evidence from different trial like E4599, Point Break, Aries, Cell, and Avel study that benefits with bevacizumab induction and maintenance, and more benefit observed in less than 65 years of age patients and male population. Bevacizumab does not add to significant toxicity, although the toxicities are manageable. And EGFR mutated NSCLC patients also, bevacizumab addition helps in with EGFR exon 20 with addition of the chemotherapy and EGFR exon 21 with allotinib arm, and especially for current or former smoker patients. So with these things, I'm stopping here. If any questions, we can take it. Thank you, and over to the organizer.
Thank you, Dr. Arnab Bhattacharya, for your the talk on the role of bevacizumab in non-squamous adeno-CA. With this, I would like to conclude this session. If there is no question, we couldn't see any question in the chat box. And I thank IAIO as well as organizers for providing this opportunity to conduct this short course on the lung neuroendocrine tumor. I thank you, technical team, as well as the IAIO board for providing this opportunity. I thank you, my speakers, panelists, as well as Dr. Arnab and the DRL team for supporting this academic activity. With this, I would like to conclude, and I will hand over back to the organizers, please.
Thank you so much, sir. Thank you for those wonderful closing remarks and for guiding today's scientific program. As we conclude today's session, on behalf of the International Association for Integrated Oncology, IAIO, I would like to extend our heartfelt gratitude to our program director and all our distinguished speaker, moderator, and panelists and participants. A special thanks to all faculties for sharing their time, expertise, and valuable clinical insights. Thank you to all our participants for joining us and making this session a success. With this, we conclude today's IAIO Expert Insight session on Lung NET. Thank you, everyone. Have a wonderful evening ahead. Good night.